morning, everyone. Welcome to the Wilson Center. My name is Sarah Barnes, and I'm the project director of the Maternal Health Initiative here at the center. We are thrilled today to be partnering with World Vision to discuss galvanizing faith-based response, engaging men and boys in HIV prevention services. We're very pleased to welcome all of our panelists here today and grateful to World Vision for supporting this open discussion on these very critical issues. For those of you who are not familiar with the center, we're a living memorial to President Woodrow Wilson, the only president to receive a PhD. The Wilson Center is a nonpartisan and non-advocacy by law. And throughout our 50-year history, as a neutral forum, we've always strived to bring a variety of perspectives to the table. So thank you very much. After this morning's event, we're having a lunch right out into the dining room, and then we'll come back into this room for another event from 12 to 2 on healthy timing and spacing of pregnancies. So with that, I would like to introduce Jed Hoffman to the stage. Jed is the Vice President of Resource Development and International Programs Group from World Vision U.S. Thank you very much.
Morning, everyone. I'm going to try to be brief. You're going to hear a lot of details about the sort of main points I'm going to make before I introduce Sean. The reason why World Vision is sponsoring and promoting this event is because we're keenly aware, and we were present for the role of the faith-based communities networks, both here in the United States and abroad, in the initial response to HIV. For those of you who might not have been there at the time, the faith-based communities played a crucial role, a historical role at both ends of the spectrum. Here in the United States, the faith-based communities, after an initial sort of being part of the problem and responding in perhaps in a less appropriate way, mobilized in the 1980s and were instrumental in creating the political capital, bipartisan political capital that ended up in the creation of the PEPFAR program and the financial budgetary support that resulted. Overseas, the faith-based communities moved to stigma reduction and to embracing the need to respond in a humane and ethical way to this epidemic. That response had two sort of basic components. One is mobilizing the existing community capacity. A lot of somebody said, I think once, that there are two things that you find when you go any place in Africa and in the developing world. You find a bottle of Coca-Cola and you find a church or a mosque. This is, I think, studies have shown that 84% of the world has religious affiliation, Christianity and Islam being the first and second largest. And 75% of Africans really trust their religious leaders. So these networks, this credibility that out there, the mobilization of that toward the identification and reduction of stigma and towards the rollout of the responses, whether it with the orphans and vulnerable children or the care and treatment programs, the prevention programs, and so forth, was key. And I had the privilege to be involved in the emergency scale-up with a few people here. Shepard, for example, and Anita were part of the faith-based coalition, which was headed by CRS. I think Gloria was also involved through IHV. Bob Redfield was there and a key part of it. I can't see, there may be other people in the audience who have participated as well. But what we saw was that the faith community also brought a commitment to ethics, to values, and to the achievement of durable clinical outcomes. There are many instances where the need for political expediency or to meet targets that were set by Congress and others that were based on numbers and deliverables, process indicators, came into conflict with the need to provide the best treatment available and to ensure that the treatment was provided in a way to achieve durable outcomes. I believe that the faith-based community played a key role in developing the community engagement methodologies that are now commonly used across all of the programs. We also, the faith-based community involvement also played a big part in pushing down the unit costs that allowed for the kind of scale that we've seen. And so there's a real motivation here for us to bring this capacity to bear on this final stage, hopefully, which is the need to address the problem with adolescent boys and young men, and the infection rates that they're the low levels of testing and the persistent stigma are driving in young girls or adolescent girls and young women. So that's why we've taken the effort here to organize this event, and we strongly feel like there's a role to play, that the faith-based community needs to be mobilized for this new challenge. So with that, I want to pass the microphone to Dr. Sean Kavanaugh, who is the lead adult care and treatment and senior TB technical advisor at the Office of the Global AIDS Coordinator. Sean.
So I'm gonna put my clock here so I can keep track of the time, but I think I've been allotted about 30 minutes, and I don't think I'll take up all of that time because we have a very rich panel. So there's a lot of discussion for us to have, and I want to make sure that we get to that. I do want to start by saying that I am obviously not Ambassador Birx. Ambassador Birx, you'll recall, is a tall woman, and she has very large shoes, and I am not going to try to fill those shoes. What I am going to do is try to convey some of our excitement about this engagement that we'll be talking about today, and some of our frustration with the challenges that we have stumbled across over the past so many years. And our hope, really, that with engaging the correct partners, that we can move forward through these challenges, that there are challenges that we can solve. So the title of the talk is Enhanced Engagement with Faith-Based Organizations to Advance HIV Epidemic Control. And what's not on that slide is a very specific challenge or obstacle in front of us that we need to get around in order to advance epidemic control. And that's what we're going to be talking about today. And that is finding men, particularly young men, bringing them into care and keeping them in care. And we'll go through a bunch of the data to show why that is a pivotal focus for us in now, actually, one would argue in the years past and certainly in the years to come. I don't have my clicker, it's right here. Okay, so we'll start with the why, and the problem is urgent. And so over the next couple slides at least, I'm going to set up a picture to show you just why, if we are genuinely interested in attaining epidemic control, this problem is in fact really urgent. So I think a lot of people in the room are probably familiar with this cycle, right? For those of you that are not, we have substantial epidemiologic and historical data to back this up. What we know is that adult HIV positive men, youngish adult HIV positive men, sexually engage and infect adolescent girls and young women, who then grow up and then transmit HIV infection to their peers as they get older, who then sexually engage with younger women, and that cycle just goes on. And it becomes like a very productive, unfortunately productive cycle. Our goal is to interrupt this cycle in as many places as we can, as many places that are possible. And I hope to demonstrate over the next couple of slides just why interrupting the cycle at the level of the men is a particularly critical one. Okay, so This is our good news slide that I think a lot of people in the audience have seen. This is from the population-based HIV impact assessment surveys, or PHIAs. And these are the 6 countries, mostly in Southern Africa, that have had PHIAs reported out. And these are the care cascades across each of those 6 countries. So just to walk them through a little bit, our goal, that bar that is kind of a purplish eggplant bar all the way on your left in each of these cascades, is the number of people with HIV that know their status, that have been tested. So it's a proportion of all PLHIV who have a known diagnosis. The bar in the middle, which is coming across here, is kind of a deeper gray, maybe green-gray. Swaziland is 87%. Those are the number of people who know their status that are on ART, antiretroviral therapy. And then that last bar, the tallest one here in the first for Swaziland at 92, looks kind of a dusky orange-brown. Those are the proportion of folks that are on therapy who have viral load suppression, right? And our goal is to have 90-90-90 in all of those. 90% of those know their status, 90% of those know status are on ART, and 90% of those that are on ART are virally suppressed. And that is a working definition of epidemic control. We get there, transmission rates tumble, and then we're dealing with incidence rates that make it a much more manageable epidemic going forward. Okay. And this slide has a lot of good news in it. You can see that maybe a major bottleneck, because the entry to care is that first bar. We're not, we're close to 90% in Swaziland, and then we kind of drop farther and farther away. And that's a major bottleneck for us, is case finding and bringing them into care. Once they're in care, we're doing a very good job of getting them on ART for the most part, and a very good job of getting viral load suppression. So there are a lot of victories in this slide. Okay, so this slide, this looks at the data from a slightly different direction. This is from the UNAIDS the blind spot report that came out last year. And this is looking at coverage of antiretroviral therapy among adults by sex and region for 2016. So this is essentially, if you were to take the first 2 proportions, the 85 and the 87 for Swaziland, and multiply them together, you would get the coverage. That's the number of PLHIV in society that are on ART. And here this kind of demonstrates that you can actually see more sobering figures. We're not exactly where we want to be. We're actually a little bit ways off. And the other point on this slide is that there's some substantial sex differences, most particularly here in Eastern and Southern Africa, but also here in Western and Central Africa, where the men and the women are fairly far apart in terms of their antiretroviral therapy. Men, and I should have said, and it almost goes without saying, men have less ART coverage compared to the women. So right away, we're worried about the men. The men are emerging as a significant demographic group that we need to find and bring into care. Okay, and now we're starting to look at the younger folks, and and the data get a little darker, a little more dire. Here's the same 6 countries that did their PHIA surveys, and here we're looking at the 90-90-90 cascades, back to those, in the 15 to 24-year-olds. And the numbers are nowhere near as shiny. Like you can see from those that are aware, HIV diagnosed, we're only starting in Swaziland at about 65%, and then we rapidly drop off. And so many of these countries are well under 50%. And that is the bottleneck that we need to contend with. Because again, once we get them and bring them into care, we're doing fairly well with linking them onto therapy. That's that red bar, and that's above 80% for all countries. And then I would say, it's hard to qualify this one, fairly well, but there's some concerns in our viral load suppression, which we'll get into in some of the next slides. So this is actually Namibia, right? I could probably show one of a couple dozen country slides that show virtually the same thing. The colors aren't showing up here as well as they did on the slides when I planned them, but your eye is drawn to this precipitous drop. These are the gaps. So I should say the lighter green at the top are the number and proportion, looking here at the right axis, that have not yet been put on ART in the country. And so you see this big drop that bottoms out with men in the 20 to 24 age group. So somewhere around 70-something% of men in Namibia in the age range of 20 to 24 who are HIV positive are not on therapy. And I want to call your attention to the fact that in terms of strict numbers, we have much higher, bigger numbers over there in the older males and females. and we have quite a lot of older males that we need to bring into therapy, but proportionately we're doing well. With our younger men, proportionally we're not doing well at all. And so that is a group we are missing with our programming. We're not getting them. Okay, so now I want to touch on this issue around viral load suppression. So if we had our target cascades achieved, 90, 90, 90, then you'd be looking at a 73% viral load suppression. That's the target here. That's where we want to be. And these bars down below are essentially the viral load suppression, what it actually is. Boys are in blue and girls are in red. And this is then distressing, right? Because we have, of the people with HIV in these different countries, an alarmingly low proportion of them are viral load suppressed, right? The complement, the obverse of that is that the other half of that proportion to get to 100, those are young men and women who have measurable viral loads, who are out there in the community capable of transmitting disease. So if you look over here, say Tanzania at the far, at the far right, Tanzania has a 22% viral load suppression among young adult boys. That means 78% of them are not suppressed and that are potentially transmitting disease. Now hold that in your mind as we go through these next slides, okay? So this is the prevalence of multiple partners in the past 12 months among young men aged 20 to 24. And this was very cleverly pulled out of the Demographic and Health Survey data, because this sets the sort of sexual behavior picture, and that viral load suppression takes on a deeper meaning. So just to speak to it specifically, let's look at Tanzania. We were just talking about Tanzania. 21% of boys in this age group, 20 to 24, have had multiple sexual partners in the past 12 months. And recall that 78% of them are not virally suppressed. Sorry, I should say 78% of the ones with HIV are not virally suppressed. So then we're moving into some deep public health concerns. And this, just to make this, this run of slides a little bit more vivid, actually gives you the average number of sexual partners that this cohort, these young men aged 20 to 24, have had, lifetime cohort. And you can see here, let's just pick Tanzania again, because that's our walking example. These young men in Tanzania profess up to 5 average sexual partners in their lifetime. So that kind of rounds out the picture. It's not just multiple partners, it's 5 partners. And these are the vast majority of them, of those that have HIV, don't have viral load suppression. So, and 20-some% of them have multiple partners, and when they do, it's quite a few partners. So that is sort of the nidus of the problem that we're dealing with. And we haven't made a lot of inroads into that cycle. And that's one of the things that's one of our bigger appeals to you today, is that we need you to help us to figure out how to do that better. Okay, I'll keep going. So sex starts early in a lot of these countries. This chart gives you the percentage or proportion of young adults who professed sexual debut at or before the age of 15. And these proportions compare actually across the globe. These are actually very similar across the globe, much lower in some Western than it is in some Western countries. Nonetheless, that's a high proportion of sexual activity at an early age, and I should say an early and relatively uninformed age, when these young children, frankly, are being exposed to life-changing risks that they often are totally ignorant of or haven't been fully educated about in order to protect themselves. Okay, so we'll talk a little bit about the barriers to male service uptake, and these are well known, I think, to almost everybody in the group. We need to say them and move forward for the rest of the slide deck with them in mind. There's some very obvious structural barriers when it comes to bringing men into care. They often have jobs, and there's often quite a bit of mobilization or migration for those jobs that make it difficult for them to come into a regular care center. And then when they do have jobs, the jobs themselves often prohibit them from engaging. It takes hours to visit clinical care almost anywhere in Africa. And there are very few jobs that are permissive for a worker to take off 4 hours to go and wait. And then there's a broad list of cultural barriers that stand in the way of engaging men in the ways that we need to. Care seeking is often counter-normative for men. Clinics are seen as female spaces. There are gender role expectations. The man's the provider, and they generally don't have time to seek care. They're care providers, not care seekers. There's stigmatizing attitudes. There's the valorization of sexual risk-taking in multiple sex partners. And there's a discomfort discussing sexuality-related issues with female providers. And the majority of providers, I guess that breaks down by country, but in many of these countries, a lot of the nurses certainly, and many of the clinicians are female. So when we're moving forward, we need to develop interventions that themselves need to increase reach into the communities, provide male and adolescent-friendly service so people stay when they come and make it easier for them, improve access so they don't have to, there are none of these structural barriers. And then we really need, as we'll get to look at in just a minute, we really need to change attitudes. And this is partly why we need to change attitudes. This is a very sobering slide that I'm quite confident everyone in this room has seen something of this. This is the percentages of 13 to 24-year-old female respondents who reported first sex as forced or coerced. And those numbers are alarming. And those numbers are often the product of gender norms and attitudes that they themselves are amenable to change, right? And we're finding that out with some of the programming we're doing. And we're also in search of the right partners that can carry those messages forward, that can help bend some of these social norms and attitudes. Because these numbers should be nowhere near, these numbers shouldn't be above zero, right? So we have a lot of work to do here. And this slide, and I love this slide, and thanks Susan for all of these slides, but this slide particularly, because this slide is the moment in the talk where we stop and remember that we've been looking at a lot of numbers for the past, 10 minutes. And behind all of those numbers are human faces, right? And so these are the women in Malawi, and these are the women who often face enormous pressures and sexual violence. So that means something more than a statistic or a proportion, right? These are people who are disempowered that we are, in a sense, called upon to try to both empower through our own programming and protect. This is the youth bulge, and this is maybe we're moving into the final little piece around the beginning, because this is like this is the tsunami that's coming, right? Everything that we've been talking about is about to get amplified by an order of magnitude. So in Malawi is a great example, but again, we could use virtually any of the countries, particularly in Southern Africa. Malawi in 1990 on the left, Malawi in 2016 on the right. And you can just get a relative sense of what the youth population was in Malawi then compared to what it is today. And what that translates to us in terms of numbers, we're kind of treading water here, right? The number of young men PLHIV in 1990 was 23,000. Today it's 34,000. It's gone up substantially. The number of young women with HIV hasn't decreased in any meaningful sense. And that's because there's this enormous demographic shift happening. And when you couple with that the idea of some of the urbanization rates that are happening, the youth bulge that meets the urbanization rate in a very uncomfortable way, because those were where the HIV incidences are the highest. Young folks moving into the city, exposing themselves or being exposed to risks that are many times higher than where they came from, leading to many, many, many more patients than we have had before, unless we get on top of this now. Okay, so this is not just Malawi, this is the rest of sub-Saharan Africa. And you can see that this, in sub-Saharan Africa is that dotted line that's ominously pointing up and up and up and up. So that by 2020, the youth population in sub-Saharan Africa will have more than doubled from the start of the HIV epidemic. And that's the storm that's actually, I wouldn't say it's coming, it's already here. We just need to deal with it in a much more effective way than we have been so far. Okay, so just a little brief rundown. Here's what we know from the FIA surveys. More than half of the men under the age of 35 do not know their status and are not on treatment. And this is fueling the epidemic, particularly in the younger adolescent girls and young women. Geography, there are vast differences in HIV prevalence within each country, and these investments must continue to be targeted for impact. Meaning we need to use our data intelligently to figure out where we do what. Right? We'll be doing a different set of interventions in different areas that largely based on epidemiology, but also on cultural norms and cultural entry points into different communities. populations. There are significant age gap in those we have reached and have not reached, impacting epidemic control. By and large, we're fairly successful reaching women over the age of 25 and men over the age of 35. It's men younger than 35 and women younger than 25 that we really need to figure out. Okay, so now we're moving into sort of chapter 2. This is the WHO. And the WHO are the faith-based organizations and faith communities that we think hold a key here for us, once again. So this is the PEPFAR, this is to remind this audience, if anyone is not aware, that faith-based organizations have had a long and prominent role with PEPFAR. They were there in the very beginning when they were taking care of dying patients, when that was all the work there was to do. And they were perfectly situated to do that. They've been there since the beginning, taking care of orphans and vulnerable children in a very careful and deliberate way and successful way. When we pivoted more toward the 90s and we got more into an aggressive treatment paradigm, the faith-based organizations pivoted with us, and they developed care models, some of the most successful ones that we've seen. So they've been there throughout the entire history, and we rely on them for actually the backbone of a lot of the different work that we do. One of the pivotal issues for us now is very clearly, and we'll talk about this more in the next 15 minutes, is helping us find men and young boys, and find them and then bring them into care. Reach them in a way that the connection is durable, they get into care, and they remain in care. They stay adherent, and they get virally suppressed. And that requires a trusting environment. That requires a very specific relationship, which we'll talk a little bit about. So this is, I'm sure everyone here is familiar with this. This was the Lancet, the special issue on faith-based organizations and their contributions to health, featured at the World Health Summit in 2015. And I'm just going to read this because I think this makes the point as pellucid as it can be made. An estimated 84% of the world's population is religiously affiliated. Faith is a powerful force in the lives of individuals and communities worldwide. This series argues that building on the extensive experience, sometimes going back centuries, strengths and capacities of faith-based organizations offer a unique opportunity to improve health outcomes. So we, PEPFAR, now need to capitalize on those strengths, that experience, and those capacities to really push into the areas where we have not yet effectively done. Okay. So, and this is a testament to the power and why we think faith-based organizations are particularly important in this effort. This was from the Pew Templeton survey across Africa, and there were many questions in that survey, one of which is, how often do you attend religious services? And the proportions here are incredibly high. There is no other institution that has that kind of reach, right? That's a platform that is amazing. And then and when you combine with it the nature of that platform, the integrity, the intention, then it is the ideal platform to reach a lot of the people that we're still trying to reach. And then we actually, in a lot of these countries, they can disaggregate by gender and by age. And you can see that for the populations that we're discussing today, extremely high numbers. There's, very high proportions of men are attending church on a very regular basis. Same for young adults. So those are the populations we know we need to reach, and here is a platform that we know reaches them. And then this is the other aspect of this. Beyond reach, there's influence. And this slide is a testament just to how influential faith-based organizations and church outreaches can be to the groups that we're trying to reach. Right? The vast majority, almost 90% up and down in these countries, would rate religion as very important to them. So that's a meaningful connection for these patients, and we need to engage them in a meaningful way in order to get them the care that they need and their communities need. And again, we have that data by gender and by age, reassuring, once again, that the populations we need to reach have a very influential and important relationship with faith-based organizations. Okay, and this slide shows, it's just a single example of again, what might be many, when faith-based organization policies and PEPFAR priorities align very well This is from the Evangelical Association of Malawi, their 2017 Sexual and Reproductive Health Policy. And there's a lot of language in here about, for example, promoting youth-parent interactions on sex and sexuality, abstinence and fidelity as first-line preventative measures, correct and consistent condom use during conjugal union. There are statements against violence, and down here there are important, very important statements on male engagement, advocate for male involvement in all issues of sexual and reproductive health. So this is a kind of policy that is lockstep in with PEPFAR, and what we need to use when we come together to engage both on a political level and then on organizational levels. Okay, so now we're going to talk a little bit on the what, and here we're talking about finding and influencing clinically well, men and young adults. How do you find the folks that don't feel any compelling need to come to a medical clinic? Well, here's what we want to do. We want to find the young men and test and treat them so that they don't infect adolescent girls and young women. We want to work on preventing violence and HIV by avoiding and reducing risk so that there isn't that ongoing cycle of sexual violence and sexual imposition. And we have some strategies that have been proven to be very effective here. The PEPFAR strategies for accelerating HIV/AIDS epidemic control are 5 key actions you'll note. We're going to accelerate optimized HIV testing and treatment in men younger than 35, and we'll talk about that in a little more detail in just a second. We're going to expand prevention for women through the DREAMS partnership, which I hope most people have now an evidence-backed effort that has been shown to reduce, shown to empower women and reduce the dangers and risks that they face. And then we're going to protect and prevent HIV in men through VMMC and hopefully some other efforts. We're going to use our data to the best of our ability to target our activities. Actually, we're hoping to build a very flexible system where we have very specific activities targeted geographically and demographically to find the people that are yet to be found. And then we're going to renew and enhance our engagement with faith-based organizations to accelerate epidemic control. And of course, strengthen contributions by partner governments to get us there. Okay, so this is our this is an example of some of our data-formed approaches that we've been really emphasizing this year. In order to reach more boys and men with HIV services, we have really pushed the need for index case testing, and we'll talk about that on some subsequent slides. We're really trying to scale up VMMC, that's medical male circumcision, linkage to other services. And then self-testing is a new effort that we've been promoting, and we have very specific niches where we think that might be useful. We have extended hours, male-friendly clinics. We're going to improve access through community engagement programs, and we're developing comprehensive programming to change attitudes and behavior. It's tricky to find the right balance between the volume of tests. This is a constant tension at PEPFAR. Like, on the one hand, if we just tested every person in the country, we would find them, but at an incredibly low yield and an incredibly high cost. We actually have data that can drive how we do our testing efforts. So we're going to use that data to target our testing and find the right balance. In some populations, there's an argument where you expand, right? You expand testing in a population because, let's say, young men aren't a group that comes in that you're easily able to target. Other populations where we have higher prevalences, we can shift our testing in ways that are data-driven and impactful. And we're doing that better and better at PEPFAR. So this is that little bit about index testing that just shows how powerful index testing it is and how much more productive or yielding it is than the other test modalities. So, but it requires the right environment. To do that well, that has to be done within the context of a trusting relationship. Someone has to elicit some pretty delicate information and then act on that information in a way that might make the index patient nervous. So when we do that well, we need organizations that have a history of an established, trusting, well-intentioned relationship with the index patient. So again, the faith-based organizations are a perfect candidate for that. Okay, so we'll end up here with the how we're going to reach men, prevent sexual violence, and avoid sexual risk. And we just have a couple of examples. We have a long list of innovative solutions that we're promoting in PEPFAR, And we're really excited about a lot of these. We have programs all over Africa and Asia that are attempting different versions of these and reporting back to us their successes, or in some cases, their lack of success. That feeds back into the machine that helps us make decisions about what we're going to emphasize and what we're going to de-emphasize. Through a lot of these, churches and faith-based organizations have a very important role to play. This is, people might have heard of the Men's Corner in Lesotho. This is a recent success that we're pretty excited about. EGPAF was involved recruiting male nurses, so it's a male-only space. And the service hours, they're open during the workday, but more importantly, they're extended beyond the workday when men are off work. And then there's a whole litany of services that are offered to these men. So you can skirt the stigma associated with HIV, saying that you're coming to the clinic for an STI screening or TB, condom distribution, other stuff. And this, like, I wish I had the comparison data to show you just how impactful this was, but this gives you a sense. In the back half of 2017, the 37% of the men that they encountered were eligible for testing, and they have some pretty strict criteria there. 98% of them accepted testing. That's pretty remarkable for Lesotho. 14% of them were positive. Again, remarkable. Now, Lesotho does have a very high HIV prevalence, but rates in Lesotho float around 6, 7, 8%. So that's fantastic. It's finding exactly who it was intended to find. So, we need to figure out how we can scale this up in other countries. We have a long list of community-based types of testing because we realize to find men that don't necessarily come to clinic, we need to go to the community and find them. And we need to develop inroads into those communities, inroads that have been established in some cases for decades by organizations such as faith-based organizations. So there's a lot of these church-based mobile wellness testing. They're a tried and true neighbor to a lot of the men that we're trying to reach. And so they have a lot more success engaging and bringing folks in. I'm going to skim over these last couple data slides because I'm practically out of time. But there's some good data to support church-based versus, this was the baby shower study that showed that women who actually had the testing done in the church had a much higher testing rate and then eventual linkage rate. And there's some studies on community-based versus home-based that show, again, the benefit of community testing. And this was an interesting study using self-test kits distributed through women, either postpartum ANC or through FSWs, all of them showing very high test yields. And this is the Global AIDS Interfaith Alliance pilot, and this is some preliminary data for men ages 20 to 24 using mobile testing. And again, we had 6% yield testing or 6% HIV positivity in churches and mosques. That's phenomenal, showing that the acceptability of that regimen. And I'm going to end here with this last slide about the Violence Against Children Survey to Inspire, partnering to prevent violence by linking data to action. So this is a collaboration between CSOs, FBOs in 22 countries, advancing prevention of violence against children and its consequences. And we're very excited about rolling and scaling that up. We have some people in the room that are involved in that. And just like dreams, like we're looking for the data to drive our programming, and the programming then to develop true safety for the populations that are most at risk. And I think that's my last slide. Okay. So that was a bit of a whirlwind. I want to make sure that we have an all-star panel here. So the next part of this discussion is going to get extremely interesting. So we invite people's participation in that.
Thank you, Sean. That was really wonderful and informative, and we are so grateful that you could join us this morning. So now it is my great pleasure to introduce today's moderator, Captain Susan Hillis, to the stage. Susan is Senior Advisor to the Office of the Global AIDS Coordinator and Senior Advisor for the Division of Violence Prevention Centers for Disease Control and Prevention. Can I also ask the panelists to please come to the stage? Susan, thank you.
First of all, let me just thank every one of you for your attention to this really important topic, and for your time and being here today, and for all you are doing and will continue to do in making a difference in this epidemic globally. So I'm going to go ahead and introduce each of the panelists now in the order in which they will speak, just to give them a little bit more time and to give you a little bit more time for your questions. We are delighted to have Dr. Jeanette Berkeley-Patton, an associate professor and director from the Community Health Research Group, School of Medicine, University of Missouri, Kansas City. She will be followed by Dr. Julie Puleritz, Director, HIV and AIDS Program at the Population Council. So many of us are very familiar with their work over many years. Ms. Debbie Dortzbach, the Senior Technical Advisor for World Relief, that is well known for the work they are doing around the world. And finally, Dr. Gloria Ekpo, Senior Technical Advisor, HIV AIDS Technical Specialist for the International Health Programs Group and World Vision. So we are really in for a treat, and they will just go one by one and give what we're calling a lightning talk, a little 5-minute talk, and then at the end, we are really looking forward to the questions that you have.
Good morning.
Good morning.
I'm so happy to be here and so thankful for this opportunity to talk about some of our work that we're doing in Kansas City with the Taking It to the Pews project. This project is focused on HIV awareness and testing in African American churches. And I do have to give full disclosure. I have not done any work in Africa, but I think as I talk about this program, you'll be able to see many of the similarities and also some of the components that address some of the points that Sean brought up in his talk. And again, Taking It to the Pews was a faith response to HIV prevention in Kansas City. I'm going to talk to you a little bit about what we've been learning over the last 12 years. In Kansas City, we have one of the longest running national Week of Prayer for the Healing of AIDS initiatives. Used to be the Black Church Week of Prayer for the Healing of AIDS that was born out of the Balm of Gilead in New York. Our program in Kansas City has been running for over 25 years. And in doing that work, our faith leaders said, you know, we're doing a good job this 1 week out of the year, the first week of March, but what are we doing the other 51 weeks of the year? And how can we address HIV more comprehensively with our members, and not only with our members, but also with the community members that we serve through our outreach ministries? And so we engaged our faith leaders in developing this project through a community-based participatory research process, where they've been involved from the very beginning in creating our research agenda, all the way through helping us to develop the intervention, to implement it, to test it, and even disseminate it throughout the Kansas City area and other areas throughout the country. And in doing this work, in establishing the research agenda, one of the things that they said up front was, we want to focus on HIV testing. And they did that because, well, first and foremost, they said, we're not going to pass out condoms in churches. Let's be real about that. And so they took that one off the table. However, what they did say was that, you know, HIV testing is not only a public health issue, it's a social justice issue. And everyone has the right to know their HIV status, especially as, you know, as this disease was really raging in the U.S. In the early 1990s. And so in doing so, we work with our faith leaders to create the cornerstone of our Taking It to the Pews project, which is a toolkit. It was initially called the Taking It to the Pews Action, Prevention, and Compassion Toolkit, and just became simply the TIPS HIV Toolkit. And the importance of this toolkit was that our faith leaders said, we need to have resources, we need to have training, and we need to have church-appropriate materials and activities that we can do to create demand for HIV testing. Because one of the interesting things was, as long as the Black Church Week for the Healing of AIDS had run in Kansas City, when HIV testing events were made available during those activities, hardly anyone would get tested. So they'd have 5 testers there, you know, on a Wednesday night Bible study where all of these things are going forward, and maybe 2 people will get tested. And so they wanted materials that were church appropriate, that church members could really readily accept. And they also wanted tools that fit naturally with what happens in the churches. So as you look at the list of tools that we have in our toolkit, you can see that they are things that happen in church. So basically, if it does happen in church, we have a tool for it. So we have sermon guides, we have responsive readings, those call and responses that motivate and unify the church members to get tested, and not only to get tested, but to get tested together. We have print and video HIV testing testimonials that are done not only by pastors but by church members as well. We also have videos that are related to how the church needs to address HIV stigma, everything from church bulletins to games that can be played in ministry groups, and motivational testing strategies that our pastors employ during church services. And of course, you have to have some Bible bookmarks and some church fans and some other things that make sense in churches. But along with that, we've been creating our Taking It to the Pews training videos, because as we developed this project over 10 years ago, we wanted to think about reach, we wanted to think about scalability, and we wanted to think about sustainability. And considering the fact that we know that in the States, on any given Sunday, African Americans are in church, about 50%. And similar to some of the other data that Sean mentioned, that over 80%, believe that religion is highly important and really guides their lives. And so in developing the toolkit, we train our church leaders on how to implement the toolkit and give them some resources. We give them some money to participate in this project. The other thing that I want to say too is that while we did engage our faith leaders, we also wanted to be sure that our work was grounded theoretically. So the Taking It to the Pews project is really guided by the theory of planned behavior, with our data really showing good success in motivating changing attitudes, changing norms, and changing behavioral control, which then shift intentions and again increase demand for HIV testing. Now, the cornerstone of the Taking It to the Pews project is the toolkit, but the vehicle is the pastor. It really doesn't happen unless the pastor is involved. And we have made a true concerted effort to not only train our pastors, but to stay in touch with them to make sure that they are not only using the tools, particularly preaching on Sunday mornings about the importance of addressing HIV, role modeling receipt of an HIV test during the church services, and more or less leading by example, because the pastor has tremendous influence in our church settings. And then along with that, the unique thing about our Taking It to the Pews project is that the HIV testing takes place during the church services. So we work with our health agency partners who come out on Sunday mornings, who come out on midweek Bible studies, and who also come out during those community outreach programs like food pantries, recovery programs, some shelters that some of our churches help to support, and they do the testing there. And so that becomes a really powerful part of the project. So lastly, I just wanted to show you some of our outcomes. We're in the third phase of this project. We've been funded through NIMH as a randomized clinical trial with 14 churches and over 1,500 participants. This data I'm showing, though, is from our pilot study. And you can see there that at baseline, this was with 4 churches in our pilot study. At baseline, about 22 to 24% of our participants had received an HIV test. The light green is a comparison church. The I don't know what you would call that. Olive green are the intervention churches. And then you can see at 6 months that our comparison churches, the participants had about 30% had been tested for HIV. Almost 50%, though, in our Taking It to the Pews project had been tested for HIV. And then at 12 months, you can see those numbers jump even more for our intervention churches, that almost 60% of all of our participants had been tested for HIV. And in the data that we collect, we try to assess for what our participants have been exposed to and whether or not they've been tested. And those things that seem to work are seeing their pastor get tested. The other thing that I didn't mention is that we have text messages, emails, and voice messages that we send to the church members as we tap the capacity of the churches, having those telephone tree messaging systems that usually say church is canceled because there's an ice storm. Well, we use them to say, hey, an HIV testing event is coming up. Come out to your church and get tested. That works along with having the testing available and accessible during the church services. So the pastors are throughout the service telling people HIV testing is available, go get tested, take someone's hand, get tested together. And then I have some other comments that I can make, particularly as how this relates to young men and older men. Thank you.
Again, good morning to all,
Good morning.
and many thanks to the organizers for including me as part of this discussion. It's really a great discussion to be had. The Population Council and our project partners have been conducting intervention research for many years on how best to engage men in HIV and violence prevention. We come to this work with the perspective that it's important to reach men both to meet their own health needs. Men, for example, often have higher HIV mortality rates due to the fact that they access services late, as well as to prevent transmission of HIV to their intimate partners. Today, I'm going to highlight findings from our DREAMS-related implementation science research with high-risk men. The DREAMS partnership, as Sean Kavanagh discussed earlier, focuses on reducing HIV risk amongst adolescent girls and young women and their male partners in a number of Southern and Eastern African countries. With funding from the Bill and Melinda Gates Foundation, the Population Council is conducting research to answer key programmatically relevant questions, including characterizing who the male partners are, their motivations for their relationships with young women, and where they can be reached with HIV services. Here, we're speaking directly to the men themselves to hear about their experiences and perspectives. I have 3 points that I'd like to highlight today. First, that men are often living in very challenging situations that can lead to their HIV risk behaviors. So as this is one slide I'm highlighting here from research in South Africa, where we collected surveys with almost 1,000 men aged 20 to 40, and we focused on that age range because, as was highlighted earlier, that's the age range for men that is most likely to transmit the virus. And in that context, we wanted to reach high-risk men, including the partners of girls and young women, and understand more about their circumstances, their relationships, how they go to HIV services, etc. And the point I want to highlight right here is that in this group of men who are based in around Durban, South Africa, there's a lot of really traumatic experiences that they go through themselves in their own lives. So on the top, you'll see that almost 60% had ever witnessed an armed attack, 40% had been robbed at gunpoint or knife point. And when you think about their own childhoods before age 18, almost 80% said that they'd been beaten at home. At a quarter, saw or heard their mother being beaten. So this context is really very difficult for them. And I could put up a number of different slides showing the difficult circumstances that they are in, ranging from really high rates of depression to really high rates of alcohol, abuse of alcohol, etc. And so they're living very tough environments themselves. So on the one hand, we want to understand that we're thinking about how to reach them and what we need to address to reduce their own risk. We also wanted to look at, well, what is the association between this and specific HIV risk behaviors? And we were able to see, usually folks talk in general about structural environments and that it's very difficult and you have to address them. Here we're actually able to see that there's an association between these experiences and HIV risk behaviors. So the bullet on the bottom highlights that childhood experiences of violence for these men were associated with having multiple sexual partners in the last year, as well as inconsistent condom use. So that's the first point I wanted to highlight. The second point that I want to highlight is that men's intimate relationships, as characterized by them, are often filled with a lot of conflict, a lot of miscommunication, a lot of mistrust. So here I'm highlighting some work in Uganda and in Swaziland, where we had in-depth interviews with men, a large number of men, talking for long periods of time to get a lot more nuance about their relationships and their lives and their motivations for having relationships with girls and young women and what that whole picture looks like and how it's associated with risk. So we talked with about 90 men in Uganda across 3 regions in Uganda with in-depth interviews, and that's a lot of transcripts to go through and a lot of themes to look at. In Swaziland, we spoke to about 40 men with in-depth interviews. And this was a very key theme that came out consistently. There's a lot of conflict in their relationships. There's a lot of need for better conflict resolution and negotiation and communication skills. So specifically, they highlighted that marital relationships were often filled with conflict, and this conflict was seen as inevitable. It just happens to everybody. And it's unresolvable. And then secondly, most relationships, whether they're marital or not, were characterized by ineffective communication and distrust, which resulted in delays of formalizing their partnerships. They said, we don't want to get married because you can't trust any partners, as well as having lots of side partners. So here's a quote here. It's caused by a lack of trust in relationships, such that sticking to one partner might cause issues, such as if she cheats. So it's difficult to commit yourself. We end up having several partners. That's someone in Swaziland. And the third point that I want to make here is we're doing some new types of analyses to understand more about profiles of different groups of men so that we might be able to tailor and target our programs more effectively. So we're looking at different combinations of everything from sociodemographic characteristics like age, like employment, and also thinking about their gender-related attitudes, touch on some of the gender norms we'd been talking about earlier, as well as various characteristics and behaviors and numbers of partners so that we can understand what these profiles look like. And as of now, we're coming up with 4 different profiles from this group of almost 1,000 men in Durban. We're seeing 2 groups of younger men and 2 groups of older men. These younger men, some of them are really very high risk at the bottom left, so that's about 30% of the sample. And then we see a moderate risk group amongst younger men. So there's no younger men who are not at risk. They're reporting lots of sexual partners. So these men, 75% reported that they had sex with a girl or young woman over the last year. So almost everyone. And then the older men, we see a group of older men who are very low risk, about 13%, and a group of older, quite high risk men, about 15% of the sample, in the way that we grouped it. And what I wanted to highlight now is that we also looked at activity in the church and religiosity here to be able to share some of that with the group here. And what we saw is that a proportion of all of these men were heavily engaged in the church, although we see that quite the highest proportion were the older low-risk men. We also see, however, that the young moderate risk men were the second highest number that was saying that they were engaged in the church, meaning that there's really an opportunity to reach some of these younger men engaged in some risk there. But the groups on the bottom, much less so, reporting being active in their faith-based community. So those are 3 points I wanted to highlight for the group, and I'm sure we'll have lots of great discussion later on. Thank you. Taking your clicker.
So obviously this man is going somewhere on his bicycle, and he has a bit of a burden on the back. So it tells us a couple things, even though we don't know who it is. We don't see his face. We don't really know his age. We don't know where he is going. But we have collected a lot of data and heard already this morning so much that my mind is really just overwhelmed, but also so eager to dig into it and help discover how we can help direct these paths so that they are life-giving and not life-taking. So that this man can continue with his work that he obviously has started, so that if he is married, he will stay with his partner and have an enriched and fulfilling relationship. So that if he has children, he will be open and honest as a parent in discussing and encouraging and supporting and creating an environment where trust is nurtured. Because actually, we're not really talking about beginning with men or boys or women or girls at the age of 10, 15, 20, 24. We're actually talking about children from their youngest age and our relationship with them, whether we are in a parental relationship or in schools or in churches and in the many, many different activities that faith communities have. So our privilege is expansive. And while we have been doing it for some time, certainly we're seeing there's much more to do. So perhaps we can take a look at this bicycle and say, okay, he can't pedal with one foot, right? Have you ever tried to do that? It's pretty tough. You need two. And I think it's illustrative of the fact that it is tough to have behaviors, to maintain them, to be supported, and that are life-giving, that do not introduce yourself or your partners to HIV and other sexually transmitted disease. So while, yes, he's the only one on that bicycle, that he has to make the decisions, he will ultimately decide where he goes, but there's a tremendous opportunity we have to help pedal, to help provide information, to help support and guide in a path that is productive. I would like to suggest a couple of ways. We need that open, honest discussion. It's not happening in the church, okay? We might say, yes, we've come a long way with testing, and we even might have some discussions about HIV, but it isn't open discussion about sex. And that's dangerous. Actually, we do a lot, World Relief does a lot of workshops with couples, husbands and wives, in a number of different countries. And we're developing together a curricula that we call Families for Life. But in that discussion, it's really surprising to me how many people think that sex truly is taboo, and even if you're married and in the church, you don't talk about it. And when we open up an entire book of the Bible called the Song of Solomon and, and read a few verses, there are a few red faces. Especially the one where it speaks of your breasts are like luscious coconuts, and I want to climb the tree to enjoy them. What a gorgeous expression that you're not going to find on a Valentine, but you do find in the Bible. I mean, isn't that astounding? And it's speaking of the joy and the expression and the contentment that is so rich in a marriage relationship, because that's what the book is talking about, that commitment over time, that family that is formed. And by the way, children are not even mentioned in that entire book. So it truly is about the relationship. And if we can focus much more on this reality, on this desire to enrich in our families, we will go somewhere. If we can open this dialogue between husbands and wives, between pastors and their congregations, between parents and their children at age-appropriate ages, and not wince at the reality of the beauty of how God made us and the opportunities he gives us to express it, and to express it fully. So we need those open, honest discussions, and we need to exploit every opportunity. We have many. They have been listed. It's not just on Sunday. It's not just 1 week of the year. It's not just in a building. It's in the community. It's when I ask for responses from our friends working in the countries where we serve as World Relief, they said to me, yes, in the marketplace, when the chief is getting coronated, when men are congregating around in tea shops and coffee shops, and it's not too likely you're going to find a lot of church leaders in the bars, but we still need to discover and integrate a lot of discussion, much more open. To facilitate some of this, we did develop a small pamphlet called David's Friend. It's a bit of an indirect way to get at some of the realities which were distributed and talked about and created small discussion groups in these venues, and including the workplace. So let's exploit those opportunities. And we have to dig into the culture. Many of the places, all of them that were displayed on the slides, are honor, shame, culture. So what does that mean? They're also very communal. So I have an age mate. I have a whole cohort of people who will come along with me in life that I can tap into. And how are we relating to those? I will close with a vivid picture in my mind of a woman from Mozambique who took me to her home. She was HIV positive herself. As I tried to focus my eyes in the dark room to the bedroom where she took me, I saw in her bed her husband dying of HIV, in another bed right next to her, his girlfriend and infant. And I was gripped with the reality that this woman, who likely had been faithful to her husband all her life, was now caring for 3, and herself, individuals with HIV and AIDS. And that cycle can be broken, but it was broken in part by her and her faithful, diligent, compassionate care, and by the pastor and the church people who came along, stood with her, and helped her pedal that bicycle. Mm-hmm.
Thank you so much for being here. We're really appreciative of your presence. And continuing with that dialogue, I'll just share some of the things we've been doing in World Vision, mobilizing men and boys for HIV prevention. And I think talking of dialogue, it's really very, very critical at a time like this, so that as we work with our communities, as we work with faith-based organizations, we are able to establish that dialogue. So working with them is more than just the program. It's more than just the projects. It's looking at their local ownership, ensuring that they own those programs, they are sustainable, and they're able to scale them up as we look at them as equal partners. So as we wait for the slide to come up, as we wait for the slide to come up, I just want to say that adopting a life cycle approach, integrated manner, to ensure that all the children in various faith-based platforms, as they grow into young people, into young adults, and get married, that they are given equal opportunity to work. The other aspect is that looking at World Vision, we've been here since 1960, doing development work in over 100 countries. And over these years, our program just started with Channels of Hope. When we saw the epidemic, we were really moved to look at households, vulnerable households and children, because of the problems they go through. And we mobilized communities and educated them, advocated for care for these children. And over these years, those programs have evolved. It's just like a tree. I'm sure when the slides come, you'll be able to see them. Like a tree, just starting with adherence support, caring for the sick and dying, just like Shane was saying, we were all there. Even when there were no medication, the church was there, ensuring that they cared for the living and the dying. And similarly, over these 20 years, our programs have grown to include prevention of mother-to-child transmission of HIV, youth programming, adolescent programs, household economic strengthening, looking at mental health, adolescent programs, key population, working with faith-based, as well as men and boys. And because of our geographical coverage over several countries, we are able to have access to households where we get to talk with the children, get to discuss with the men on the issues that concern them. Looking at the best practices for our programming, I just want to draw your attention to that vivid picture that Janet was creating. And we look at faith-based platforms. Most faith-based institutions, they have a lot of networks. They have a lot of associations under them. And majority of them will have a school, like a institution, either a secondary school or primary school, just to ensure that they have places where their children could go to. And then in addition, they have health facilities, maybe a dispensary, maybe another teaching hospitals, depending on their capacity. And they will always have a social arm where they care for the vulnerable, where they care for the orphans, and so on. So on top of this is the beehive of activities. Thank you very much for the help. On top of this is the tree I was talking about. We started with Channels of Hope, reaching out to children. And over time, we have engaged faith-based organizations. We are continuing to engage them, and we'll continue to engage them until there's epidemic control. We have worked with community volunteers. We've worked with several cadre of people at the community just to make sure that these people receive the care they need. So coming to those best practices we have, I'm just following with Janet to just bring you to this church. The church is organized. They have sermons, midweek activities, and in some assemblies, they even have household cells where they meet midweek. In there, you find boys, you find girls, you find women, you find men. Mostly well. The very sick ones won't be able to come to church services. And on this, the pastor does not work alone. He has an army or soldiers or volunteers who are there every day of the week doing one thing or the other as teachers or volunteers, engaging to make sure that whatever is the mission of the church, that is implemented. And then on top of that, we have Sunday school, church services, community outreaches, like Janet was saying, and community fair. So these are untapped resources, untapped platforms, whereby we could engage faith-based organizations to do things. And I'll just share some of our experiences doing that. So, and we just believe that a well-informed and mobilized faith community maximizing on its platform will really help drive this health agenda. Because if a church wants to build a school, they know how to mobilize themselves in a sustainable way and within a particular time build those schools. So why don't we steer them up with that energy so that they see health as a project? So not just the spiritual health of their congregation, but the physical health and wellness of their members is a win-win situation. And talking of their engagement, we work with them, the leaders. The leaders are key. If a leader does not open the doors of his or her congregation to you, you cannot do anything. That dialogue with them, it may take a while. They want to know if they can trust you. They want to know how long are you coming to work with them. If they just see that you just come in, do your project and go away, they will make the work difficult for you. But if you engage them, stay with them, identify their needs and work with them, one is able to achieve those. And one of the long-term presence of World Vision is in our area development program, where we devote 10 to 15 years, get to know the community, get to know the churches, get to know their challenges, and identify with them what are their priorities. And we work with them to implement those. And then channels of hope. Those early years, it was very, very stigmatizing. You know, it was easier to die than go through the stigma and discrimination associated with HIV and AIDS. And the church was there to mobilize the health action teams to ensure that stigma was down, they could care for the needs of the people. And we are now also looking at this health information booth. How can we call it health kiosks? We are piloting it in Zimbabwe. How can we bring this health information that's available at the health facility to the community, so that to the worship centers, so that the pastors and the church workers will provide the information and make the necessary referrals. Dream projects also, we are working on those to get the male partners of the dream girls, because they are very, very interested in what we're doing and how to engage them, as well as voluntary testing in medical male circumcision. And as I round up, I just want to say that focused testing, index case testing, is really very, very key. And in our data, we've been able to identify the various age bands that are receiving the test. On the left-hand side are the various age groups that are receiving the test, and we still need to do some more work among the younger male age groups. On the right-hand side is the testing for at-risk population. We're looking at truck drivers and sex workers, mining, and mobile population. And we find out that the HIV positivity rate in these hotspots or hot profession is really high, some ranging from 21% to almost 69% when we work with sex workers. So there is opportunity. Those platforms are there. And I just know if we maximize them, we will be able to achieve our goal of controlling the epidemic. Thank you very much.
So you've all been so attentive, and we appreciate it. That was that was just an amazing panel. So thank you all so much for your complimentary and important contributions. We'll now have time for questions, and we would ask you if you have comments, potentially withhold those, because we really want to focus this time on opportunities for people with questions to ask those. I'll go ahead and take 3 before we begin to address them. So anyone who has a question? Yeah, Gretchen.
Okay, can you hear me?
Yes.
Okay. I was wondering, in all the materials that you did to try and get men to test, if there were any particular messages that you found particularly motivating, or lines of thought that you used to kind of persuade people to test.
So let me say,
We're just going to take 3 questions, and then we'll go ahead. Go ahead. Another question? And if you can, just say your name and where you're from, that'd be great as well. Yeah.
Diane Seeger, what is the course of treatment after you discover these people? Is it difficult to get into the course of treatment? And also, are there arranged marriages? And how does that work out if you know or don't know that the person is HIV positive?
Great. Sean, I neglected to ask you to come back up to if you can come on up, that'd be great. And one more question. Yeah.
Dueling banjos here. I'm Lauren Erickson-Moman, and I'm with the Division of Global HIV and Tuberculosis with the CDC. So Sean so eloquently outlined that we're kind of on this convergence of both population and geography. And we've been so actively engaged with the faith-based community since the onset of the epidemic and the PEPFAR programming. Some of our greatest strategies have been in the most rural areas. As the epidemic is changing and is more and more presenting in urban areas, I'd be curious to hear what some of our faith partners are envisioning in changing of program, not so much the hardest to reach populations in those very rural communities, but reaching men and young boys in urban settings. This is a big challenge for us.
Great. We'll go ahead and take those. And so, Jeanette, you can start with the first question since it was directed to you.
Sure. I was going to say, first of all, we universally try to encourage everyone to get tested. But some ways that we have found that our young men are more likely to get tested is when we provide the testing in our outreach ministries. But as I'm sure most of you know, in our churches, almost 65% are women who are attending churches regularly, the other 35% being men. And so our rates of testing are reflective of that. It's representative of that. But we find that we get more men tested when we provide the testing during those food pantries, during those social service activities that happen through the outreach ministries like utility assistance and those kinds of things, as well as through recovery programs that churches are offering. We've also found, particularly for the younger men, that when we have led discussions or focus groups or meetings that are focused on talking about sex, the boys come to that. And we give them a small stipend and feed them. And they come and they open up. And it's really been in those settings that we provide the testing. And they leave the discussion, go get tested, and come right back to the discussion, similar to what we do in the church setting during the Sunday morning services. They can get up from service, go get tested, and come right back because we use rapid testing. So that's been a way. The other way that's worked, where we see more men attending programs that are church-sponsored as well as getting tested, is when they're sports-related. So we have some annual activities where the pastors get together and they, Missouri and Kansas, it's a big rival, right? And the pastors play each other and they bring their young men ringers to play with them. And the young guys will come to those and will get tested, especially as the pastors encourage them throughout those sports, events to get tested. So having the testing accessible, having those male leaders, giving them a chance to talk about sex because they really want to. And they want to hear what others have to think about it, along with testing through those outreach ministries have really been successful for us, for the younger men.
Thank you. Why don't we go ahead to maybe the second question about course of treatment in arranged marriages. I don't know if, Sean, you may want to start.
Actually, do not. No, actually, I should say I do not, because I don't know. I thought it was a very interesting question, and I'm not aware of any specific programming that we're doing specifically for arranged marriages. Now, the Dreams Initiative, which we talked a little bit about today, is in some ways a prophylactic against any kind of coercive environment for women. It's the idea of the Dreams Initiative is that women are empowered starting at a very early age. So as they mature, that they're more resistant to situations that put themselves at risk. And this might be considered there, but I'll be honest, I don't know if we have, there's others in the room that might. I don't know that we have specific programming within Dreams around arranged marriages. No?
Well, yeah. Sorry.
No.
Sorry. Gretchen Bachman from Office of the Global AIDS Coordinator. So I think that within Dreams, what we have more often is a lot of work around
trying to dissuade and prevent early marriages, child brides. So I think that's incredibly important. And it's something that we've really worked very much with communities on, because really they're the one, it's a very, I think of Malawi, where there's some areas where we worked, it's very common, and having those community groups and community leaders, both faith groups and others, elected officials coming in and really, in some cases, dissolving marriages when the girls are very young. So yeah, so I do think that Dreams addresses it from that angle, and obviously a big push on delaying marriage until girls are older and boys.
Now, you also had a question about course of treatment. Did you mean is treatment available? Was that your question?
Once you these men are tested, what do they do after that? The follow-up. And how long is the course of treatment? And do some of them say, well, I don't want to go through it, I'm embarrassed, but yet it takes a toll later if they're not treated, at an early age. It's just going to follow them through their lives. What's available?
I can just give a quick comment. For our projects that we're doing in churches, in our intervention churches, the Taking It to the Pews churches, we have our health agency partners there providing not only the testing, the counseling, but they also provide a linkage to care coordinator, so that if we find a positive test, and I have to say rarely do we, but what we do find that there are a lot of people who are positive that have been lost to care that are sitting in the pews. And in us having this project, they come forward and they feel like, wow, my church is embracing this issue, and now I can disclose to my pastor and to the health agency folks that are there, particularly the linkage to care coordinator, that I'm positive and I've been out of care. And so we've been able to get people into 90-day linkage to care programs that ensure that they have health insurance, that they have a medical home, that they make it to their appointments with their infectious disease physician, or even if they need housing or food or other things. So we have that there on site when we provide the HIV testing.
Are we still on the testing one? Mm-hmm. Okay, great.
Well, arranged marriage. This is an area we really need to get into much, much more, because there's also a very positive element of arranged marriage, and many, many marriages in our world are arranged. So there's opportunity for this covenant relationship, which was usually between two families, and the opportunity to really educate, to talk about, to bring up these issues of responsibility and opportunity for multiple generations, and for the honor to be there for both sides. And often there is a commitment of a dowry or a bride price. It can be extremely positive in the sense of protecting and encouraging open, honest communication.
Thank you. Gloria, did you want to say something?
Yes, I just wanted to follow up on the cost of care, and thanks for that question. Because of the generosity of the American people, most of the PEPFAR targeted countries, the antiretroviral drugs are free. What we usually do is, initially we gave some time from the time you are tested. We call it pre-ART, to allow you get adjusted to taking the medications, and in that process we lost a lot of them to follow up. So there are new policies that is test and treat. As soon as you test positive, you're screened and you counseled and then initiated on treatment. And that brings back to the role of the community piece. Much of the work that is done, by the time a lot of things is done at the community level, almost 80%, before somebody gets to the health facility to get tested. And thereafter, the work continues. And that's where expert clients, people who follow up the patient to ensure that they adhere, for us to get to that 90% target as Ian talked about. And the key thing is staying in care, retaining in care, so that there's viral suppression and chance of transmitting to other people are very much reduced. Yes, that's treatment.
Yeah. Did you want to add anything, Sean?
Maybe just to say, because Dr. Ekpo, I think you said everything excellently. The focus, the end game is to get them to viral suppression. Every single person with HIV, we want to get them to viral suppression. So this endeavor, this test and treat, is an extremely important aspect for all of PEPFAR. As soon as they test positive, you get them started on treatment, if you can, that same day, that same minute. Mm-hmm. And so we've developed some innovative program to do that. And so once they're on treatment, they're much more likely to stay on treatment with the right support. And then effective treatment, right, to make sure that whatever they're taking, they're is effective against the virus in their body, and also it's something that they can take without too many adverse events, right? So it's amenable to them, it's effective, and then we get them to viral load suppression, and that's the end game, and that means enormous clinical benefits to that one person, and then it means community benefits because you have stopped transmission. So there's a big clinical, and this is a perfect example of where a clinical and a public health ultimatum meet right together in that one place at viral load suppression. So everything we do in PEPFAR is geared toward getting our patients, the patients in the community, to viral load suppression.
Yeah, I'll just add one quick thing, and that is that in some of the work that PEPFAR is doing in collaboration with the Global AIDS Interfaith Alliance in Malawi, and I know, Sean, you had a slide about it, that's actually a rural area of Malawi, and to get to the part where there's church-based testing, you have to go 17 kilometers down a muddy dirt road. And so you can imagine someone positive, how do they get out to get their treatment? And if they can't get out, they're actually volunteers in that community that have bicycles that will ride out and try to help get the treatment and help get it back. So it's a great example of how some of these community faith, interfaith partnerships are accessing populations that without them, I think it would be really hard for relatively lowly funded health systems in so many countries to really get to this test and treat point. So let's go on to Lauren's question. The faith partners now in urban areas, can you all speak to that?
Okay, yeah. Thank you very much. I think looking at the structure of faith-based partners and the fact of that trust, that confidentiality of their leaders and the volunteers they have in church, the opportunity I see at the urban areas to build on this trust, like the issue of index case testing and self-testing that Sean talked about. Where there is disclosure and you trust somebody, we are able to follow through, follow up, and ensure that the test is done and then confirmed at the health facility. So I think the church really has a role, not just on the preaching side, but to be like a bridge between the community and the health facility to ensure that whoever is tested is followed up in their various, pastors do visits. Members visit people almost in every situation, marriage, death, graduations, and things like that. Such opportunities could be extended for other vulnerable people in the community. And I think that could be done at the urban center as well as rural center. So to control the epidemic, I think that's an opportunity for the faith-based to tap on that trust and confidentiality to be able to support care. Thank you.
In terms of the urban area, it is not easy. Men are clustered in our cities. They've come for work. They're away from their wives for long periods of time, their families. They lack the social support. I know Julie's a social scientist, and we really need a lot more help in how to not only help educate and be a support to these young men, these 20, that really risky age group that are clustered in cities, but also see it as an opportunity because they're there. They don't have to walk 17 kilometers. And the follow-up that local churches and pastors and faith communities can provide is so much more available because there are huge numbers. And I'll just finish with, I one time was showing a video in a church after the service in the urban poor community of Mukuru in Nairobi. And I showed the video. It was pretty open, pretty specific. And I looked out, and there were lots of men who had clustered in the windows and outside the door to watch. And so we decided to show it again. And more people came. So it was just like a huge opportunity. If we had testing right then and there at that opportunity, if we had volunteers in the church, the way we do with community-based treatment for TB. So we had people really observing and helping and encouraging because the trust is there.
Great, thank you so much.
And just one thought, thinking about the myriad community-based programs that do exist now and trying to think about the lessons learned across them in some of the urban settings. So I think that faith-based groups can often reach folks that others cannot, but there's still also a number of community-based based programs now that are trying creative ways in urban settings that you could bring lessons to your experiences. So some of the, for example, we're doing some work in informal settlements around Durban, which is a particularly challenging environment in the way that you just described, with the men coming in and out, the women coming in and out also, for work, et cetera. And building this around some of the manual-based activities, like what you were talking about, to build almost a little sense of community in this informal settlement, because a lot of people don't know each other, right? And so, for example, some of the groups like Stepping Stones, or some of the groups like Sasa in Uganda, or they were trying to work on the community, or Tostan, work on the community setting to try to bring both men and women and separate them into older men and older women, and younger men and younger women. So some of the models are having same peer groups communicate well with each other and then come back together to discuss and request things of each other. So for example, some of the younger women coming back and saying, older men, we really don't want to be solicited outside of our schools, et cetera, and talking about that as a community and how to address that. So I think there's some good evidence-based programs that one could also learn back and forth.
Thank you so much. That was a great comment. Okay, I think we have time for another round of questions. Oh my goodness, like 10 hands come up. So you can decide. You can take the microphone to the person of your choice. Go. And so, can you introduce yourself, please?
Yeah, I'm Françoise Risa Kayuzia. I'm with Action for Reproductive Health in Uganda, and we do maternal and child health, and we use male involvement. We actually use them as change agents for maternal and child health. I've noted that Sean talked about the gap between those who are aware of their HIV status being 77, about 77. Our experience is that we have found out that there's still a lot of stigma among the men. That's why they don't come up for testing, although Uganda actually has done a lot with HIV and AIDS. He talked about one of the approaches that I love, that's making male-friendly clinics. I still think that these men are actually not going to come for those to the clinics to check, because they still have that stigma. I just wanted to find out from Sean whether you are considering to make it like general, such that when a man is coming to test, he's not thinking about who is going to see him coming to check for HIV or any STIs, but rather to make it general, like where you can also check for prostate cancer and all the other,
Great.
Yeah, diseases.
Okay, that's a great question. So we'll keep that for you, Sean. You want to go to someone else?
Susan, over here.
Oh, okay, Shepherd.
Shepherd Smith, Institute for Youth Development. Two quick questions, each require a little background. The first for the panel. The largest African-American church in the Norfolk, Virginia Beach area here in Virginia requires premarital HIV testing. And I don't know whether that's an entry point or not for churches, both here and abroad, or whether that's being done. And the second's for Sean. In 2002, we took several groups over to Uganda to try to understand the significant decline in HIV infection. And while there, we went to Rakai, where they were following a cohort of 18,000 people. And they queried them every 6 to 18 months, divided them into three groups. One, those who had abstained, those who had sex but didn't use condoms, and those who had sex and did use condoms. The abstinence group obviously had very, very few infections. The group that had the most infections by far were those who had sex and used condoms. Those who had sex and didn't use condoms had the lowest rate of infection of those two groups. And when they broke them down, the ones not using condoms were mostly those in committed relationships. Those who had the highest rate of infection but used condoms had by far the largest number of sexual partners. And the Museveni's at the time were promoting a strong be faithful message as well as getting young people to delay. So my question is, if number of lifetime partners is the biggest predictor of an STD, as CDC says, why hasn't there been a strong emphasis on partner reduction, both here and abroad, and a strong emphasis on delaying sexual debut for young people? Thank you.
Thank you.
Good morning, everybody. I think I need all your help.
Can you introduce yourself, please?
Yes, I'm Annie Kayaban Wilderman. I'm a development advocate, USAID and US Navy trained as a civilian engineer, total quality of life, fleet and family readiness. My question is, if to the panel and everybody, have you used or are intending to use a strategic path from our program to faith-based, not directly to the church, through the church, but through sectoral organizations, which I found very powerful and successful in Olongapo City. I organized market vendors, photographers, and all sorts of elements of the society, scavengers, and proven all my initiatives were successful. So from the faith-based group directly to the social sectoral organizations, and then we will use the faith-based. And I say that because even with the Christian community, they will tell me, Annie, I am not, praise the Lord, which is referring to the Church of England. We are Rome. Thank you.
Okay, thank you. Okay, I guess we can go ahead and start with the first question about, I think it was to you, Sean, about this idea of, I guess, wellness clinics, and can you comment on that?
Yeah. I think the root of the question is how to deal with stigma. What's the best way to deal with stigma? Your concern is that if we set up HIV-specific clinics, the men still won't come because there's stigma associated with those clinics. And there's a tension amongst those that work on stigma about the best way to deal with stigma, right? One is we can skirt the stigma by almost, in a sense, disguising the testing. And we do that quite a bit. It's a very effective strategy. You bury the HIV testing in other activities so that the clinic is not identified as exclusively an HIV testing facility. And that's part of what they're doing in Lesotho, and I think you're exactly right. I think that's part of the reason that was successful. They have a whole list of activities, male-oriented or male-specific activities, and HIV testing is just one of them. There's another strategy around stigma, which is that ultimately, in order to overcome it as a social norm, we need to sort of get more public with it. Like we need to really bring it out and try to be a little more evident. That's the longer game, we say, right? And it's a harder one to play because you need to get folks that are very well known, celebrities or influencers in the community, to be out there and be forward about HIV positive status. And the more that people are willing to do that, and then the stigma comes down, then what we've opened up, not just that one clinic, but other clinics that deal with HIV. So that's the longer game, and in some communities, they're ready for that. So there's a big push to try to diminish stigma that way. But in many of the clinics where I've worked, the tactic has been similar to what you suggested, which is that we offer HIV just as part of an array of health tests that are geared towards men's health. And I think we have good evidence showing that particular strategy is successful in a lot of the communities where we're at.
And
Just to add a couple of reflections about our experience evaluating and implementing stigma reduction programs, that one could also bring that out to the community, where you have, for example, a wellness mobile unit, where you're not necessarily highlighting the HIV. So we worked with mostly men truckers, and we were able to kind of situate that at the customs when they're crossing the border, and they were able to get HIV tests, but also address ergonomic issues with sitting long periods of time as a trucker, or diabetes, or blood pressure, and it attracted quite a few men, thousands and thousands, and almost everyone were willing to get tested, and they were very concerned about being considered vectors of HIV and being stigmatized, and that was one way to meet their needs and link them to testing and services as they needed. The other reflection I wanted to share was around in the clinic setting, that most of the successful interventions that we've seen or we've conducted is a really whole clinic approach, where it isn't just training a physician or training a nurse, because stigma is experienced by, it's reaching out to the ward cleaners, it's reaching out to the receptionists, because stigma kind of permeates everything when you're thinking about HIV, or you're thinking about stigma related to sexuality, because there's a lot of questions about should these people be getting services because they're under a certain age, et cetera, et cetera. And so addressing stigma was important to think about a policy across the entire clinic, so everyone got behind it, and they agreed not to interact with patients in certain ways. And that was very successful in Vietnam, for example, or Bangladesh, and a couple of other places where it was mostly male clients.
Just one other quick comment on that. We provide not just the HIV testing, but we also provide STD testing, and we'll next month, in a couple of weeks here, we'll also be providing hepatitis C testing. And because we're not concerned about index testing, our pastors really promote that everyone get tested. Everyone needs to know their status and get tested at least one time. And so they really promote the fact that, it's not a matter of risk or who you are. It's a matter of, as a community, we all need to know our HIV status. And so in that way, we get large numbers of people to get tested at one time, including men.
Okay, we'll go on to the next question in just a second. I'll mention that in the Rwanda model, and in their experience, they've combined this wellness testing with faith-based collaborations, and a number of the large churches 3 times a year will have mobile testing actually come to the church and be available outside, but it's wellness for multiple types of diseases as you're proposing. So I think we can go on now to Shepard's question about any consideration or experience with this counseling couples that are getting ready to get married about HIV testing, or any observations about the importance of decreasing number of partners and delaying initiation of sexual activity. So we'll turn that over to anyone who would like to speak to either of those.
I always love to speak to that. So thank you. That was a very pertinent question. I've been working in HIV/AIDS for, 25 years or more, and came to a realization that we weren't getting to some of these root issues adequately. So focusing more on the family and what is communicated, how trust is built, the things I had talked about before, was very critical to the faithfulness aspect. In other words, it's not enough just to talk about it or have a billboard about it. It really has to be discussed more openly and really encouraged as couples and also as young people for abstinence. The manuals that we have that are it's really a whole movement, really, with 18,000 couples, for example, in Burundi, that was a spinoff of savings groups. Those also are open and are used by churches for premarital counseling. So it's quite an exciting way to really introduce faithfulness for a lifelong opportunity.
Are there others from the panel?
I mean, I'm sorry, go ahead.
No, you go ahead. I'll come.
So your question specifically was, why isn't there a greater emphasis on sexual partner reduction or abstinence? And that's a tricky question for me to answer, one, because I'm not at that level where I would make some of the policy decisions, but also because in the organizations where I have worked, those emphases are there, and they've increased. So they're targeted to the right populations in an attempt to do that. That's part of DREAMS, and around the empowerment of DREAMS is an education around sexual risk and limiting the number of delaying sexual debut and limiting the number of partners. It's part of the educational package also for OVC. And then we have Protecting Life initiatives that are geared toward that. But it's a totally valid question, because it hasn't been like the absolute cornerstone, or it hasn't been. And I think that there's some older data, probably American data, that might not lend itself across. Some of that might be culturally bound, that showed that some of those programs weren't as effective as other programs. So it's a matter of finding the right programs that fit. And you're right, there's data in the Uganda data that's good and culturally relevant, geographically specific data that then reads very loudly over there. So there's different programs that are looking at that in different contexts. The prevention piece is increasingly important for PEPFAR. As our countries are getting closer to epidemic control, finding the right balance in your portfolio between case finding, treatment, and stopping transmission that way, and pure prevention is a major activity for us. So we're finding, we are looking at what are the most compelling and effective prevention activities, looking to the data. All of this will be data driven. And so when that data comes up and we find like niche data that's very specific for a group that we think that we'll get some traction and value there, that is activities we will definitely engage in. And I think you'll see in around the niche areas where that data is shown to be directly relevant, we'll be using that more and more.
Thanks.
I think there was some, yeah.
Yes, I just thought to wrap up the issue of premarital counseling, an issue of stigma regarding HIV and AIDS. I think just like initially having any of the sexually transmitted diseases like gonorrhea or syphilis or tuberculosis was very stigmatizing. The same thing with hypertension. But as we talk about it, we discuss about it, like in one of the countries I visited, we just sat under the tree with the community care volunteers. And I was asking them, are you not shy that you're sitting under the tree discussing issues of HIV? So they said they don't have stigma here, because even the HIV positive people want to be like them because they've been empowered. They talk about it. So we're looking to a situation where talking about HIV and other male wellness is an open secret, so to say, so that as we talk about the stigma and decrease, people are not shy taking their diabetes medicine or antibiotics in public. So who cares what those pills are? If we can talk about HIV the same way, then whether you are taking vitamins or antihypertensive drug, you just know it's time for you to take your medicine, and people will give you that space for that. So there's more dialogue around that, and the more we talk about it, the more it decreases. Yeah. Thank you.
Okay, thank you so much. We have time for, I think, finishing this one last question, and maybe one more if there's an urgent one, and that is, can any one person talk about your experience with either multi-sector or multi-stakeholder approaches, which is what you were mentioning, really, to increasing our ability to reach men with HIV testing?
I will. We are structuring, and have been for some time, churches coming together from all different denominations in what we could be called a number of things, church empowerment zone. And within that, they form committees. And these church network committees' purpose is to reach out into the community around them. So it's one voice, a unified voice, many different denominations coming together, learning about the issues, not just HIV, but also maternal health, family planning, violence against women reduction, all of those things, and then going into the community to engage those vendors and individuals stopping at the border for a truck stop. So it's very much designed to be outward focused, not just inward.
Thanks so much. And is there one last urgent question you feel like you have to ask? I think you had your hand up first and longest, so let's go ahead and let you finish this off.
Good morning, everyone.
Good morning.
My name is Ugo, Dr. Ugo Chukwuamaniwe. I am part of PEPFAR, Sean is smiling. I work out of USAID, Office of HIV and AIDS, care and treatment team, but I'm the focal person for community care and prevention with people who already live with HIV and AIDS. So as American as I am today, I was actually born in sub-Saharan Africa. So I want to make my comments, and then what I was hoping was a question, and I'm so glad somebody it's already come up. So sorry, I wrote them down so that I don't get too excited, because this platform have waited so long for us to get here. We're finally here. First of all, thank you very much for this amazing panel. Thank you, Sean, for bringing it down and simple. So but the most interesting thing is that everybody in this room is the choir. I don't know if you're feeling that with me. Everybody in this room is a choir. And before I forget, I want to say thank you to Ms. Derby for giving us that very dramatic example at the end. Just yesterday, I was talking with my colleague, Suzanne Leclerc-Madlala, and we're like, how are we going to go and sit there quietly and the whole session will finish and nobody will bring that kind of thing out? Because the reality on ground is that no matter whether you're in the urban or the rural area, because of the socio-cultural context in most parts of sub-Saharan Africa, what she described on different levels or in different variations is a reality. That woman who got positive by just getting married ended up from the bigness of her heart looking after the other woman or the spare tire or whatever they call it in that country, and her child and herself. And she was probably describing when we didn't have ARTs all over the place. Now we have ARTs all over the place. Something similar is still the norm. But having said that, I noticed some things here that tells you how difficult this simplistic kind of thing we're doing here is. Has anybody noticed that outside of Sean, who was not on the panel, there's no man there? Okay. So the rest of all of my comments, I'm going to try to make it short now, is around stigma. And the ultimate barrier to everything we do, whether it's men or women, is the stigma. But the faith-based people, the faith-based platform is the platform that pushes stigma, and it's also the platform that can help us fight stigma. We, the faith-based people, push the stigma, knowingly or unknowingly. And only the faith-based people can help with the stigma. That is the barrier to access, to testing, to treatment. Another thing I noticed here, what is our faith-based? Thank you, Dr. Ekpo. I think only one picture on her slide reminded us that faith is not only Christianity. In sub-Saharan Africa, Southeast Asia, and everywhere else, there's all kind of faith. There's Islam, which is in sub-Saharan Africa, it's almost 50-50 if you pull all the countries in one. And there's the traditional beliefs, which is actually what pushes the whole of Africa. You'll be amazed how many people with 4 PhDs still go to their Sherman, including doctors who treat HIV. So how are we going to spread out the faith thing? And then, I don't know if it's still a question, because now you've brought up stigma. What are we going to strategically do as a faith-based platform to engage addressing stigma beyond our research and numbers, which, based on what you just said, I'd written, how do we take the nascent successes, like the one Dr. described, take it to scale? We don't have time to do an RCT, randomized control trial of how the faith-based works. What we're looking for is how to scale it up. So this is the choir here. How do we do that? I just want to give an example of something the faith-based can engage. sexual abuse and molestation is pervasive in sub-Saharan Africa. Nobody can address it. Like Debbie has been saying, bringing it out in the open. Only the faith-based community can start speaking up in their countries, whether it's the Muslims, whether it's the Christians, or whether it's the Shermans, and start talking about the fact that all those kids who get sexually molested and is accepted as norm should stop, if for nothing else, because it's happening, it's still happening, and nobody talks about it.
Thank you so much, Ugo, for that comment. And I guess the question embedded in it, is there anything really effective that we should be doing now going forward as faith communities to address stigma? And I think we have time for only one respondent. So who would like to respond? Do you want to, Gloria? Thank you.
Just like, thanks, Dr. Ugo, for that comment. I think just like the church at the earlier time was not fully embracing the reality of the impact of HIV and did not really embrace compassion on its members to see how much it could help. We have come a long way. We've learned a lot over these 30 years. And I think the evidence is that at almost all levels, be it tertiary, community level, we see footprints of faith-based organizations doing things. And I think we could trust them at this time, having learned and there's evidence of what works, to be able to push the last button to drive away stigma, to drive away gender-based violence as these are handled at the pulpit and within the pew. So I think that still the faith-based still has opportunity to do that.
Thank you. Please join me in giving our panelists a big hand and our discussants.